what's upcoming in the interventional cardiology world that you can provide a synopsis on, things that you think that physicians should hear about regarding reimbursement, regarding technology, regarding research? What's coming in the field of interventional cardiology that excites you and you and your team's working on?
Well, I think there's no other field in my mind that's more exciting than interventional cardiology, because we're so devoted to scientific work and research, and every single question that comes in front of us, we put it to test in our patients with prospective randomized clinical trials, and we are very much probably give the most number of evidence-based studies to our guidelines. And this is some of the things that I'm extremely proud of, because we're such an inquisitive bunch, and we're always looking for cutting edge technologies and best possible way forward. And I think the future is extremely strong in terms of what we're doing in med tech, but also how we are combining intervention to prevention and really enhancing the outcomes of our PCI in the most complex patients. Our job starts in the cath lab, but it doesn't end in the cath lab after the procedure is done. It actually becomes a new journey every time you meet a new patient in the cath lab. And how will I now make this intervention durable once this patient leaves my lab? What am I going to do in terms of forming a very good team approach with that referring physician to be sure that prevention and all of this new technology that's coming forth in terms of lipid reduction, SGLT2 inhibitors for enhancing renal function, heart failure, and every single other thing with AFib ablation and left atrial appendage closure. But then what are we doing in terms of maintaining these patients in sinus rhythm? All of these things that we have in front of us have to be coupled. They don't just end in the cath lab. I did my procedure, I'm waiting for the next one. It's the beginning of a journey now with that patient and the referring physician. And I think the interventionalists have a huge part in this. And we continue to enhance how we do our procedures in the lab with intravascular imaging, use of physiology, really being judicious in not overstenting, not understanding, and understanding who really needs an intervention. But then coupling that with the best prevention going forward. We cannot have patients come back to the cath lab that we just treated 3 months later with an LDL of 120 if we just put a stent in their left main. And I think that, to me, is unfinished business that needs to be part of our armamentarium of how we then make our interventions durable. And I think now we have great opportunity with all of the great new drugs that are coming our way.
Thank you so much. That's really what we're looking for. A last question that is, I'm a little bit of bias, and that's question, so bear with me. I'm an interventional cardiologist with endovascular or vascular specialty. This is what we do most of the time, and a lot of colleague viewers does the same. But I still feel when we talk to our cardiology fellows, IC fellows across the country, the focus in the half of their cardiovascular fellowship is being missed. What do you think the role of the ACC and the SCI and the CRF to emphasize the importance of a complete holistic treatment of cardiac and vascular health in our patients?
I actually think it's a huge missed opportunity. Every time a patient comes to the cath lab, it's an opportunity for them, not only because they're having an event, obviously that's why they're there, an invasive procedure in their heart, to have a full evaluation of their extracardiac vasculature. Because if there is blockage in the coronary arteries, chances are there's plaque in the carotids, there's plaque in the legs, and there is a lot, and that kind of missing the opportunity of understanding what's going on outside of the heart is truly a missed opportunity. I also believe it's an opportunity for the patient to become more engaged, because you basically tell them what exactly is going on, and that the plaque in the heart is also outside of the heart. And what we just fixed was just a couple of millimeters. There's so much more that's going on. And that plaque outside of the heart is almost more predictive of worse events down the line in those patients. So not making those diagnoses, not spending the time that we need to do to make sure that patients are fully understanding, keeps them less adherent to the guideline-directed medical management of these patients and getting their LDL to where it needs to be, their triglycerides, their hemoglobin A1C, everything else, and then missing an opportunity for, let's say, a 90% carotid stenosis that got missed because no one ever looked at it, and that patient has a stroke, where we know that guidelines are recommending revascularization of that carotid stenosis, whether it's percutaneous or, depending on expertise, endarterectomy. And I think in my mind, we really need to think about the interventional cardiologist as the harbor of the place where you could make a difference in our patient's journey and completely changing the trajectory in a positive sense. If a patient doesn't come back, that is what you really should be celebrating, not the fact that the patient is in for multitudes of procedures for you. It literally is a failure, because each time a patient keeps coming back, to me, it's a failure. It's a failure that I didn't diagnose the carotid stenosis. Now there is a TIA. How did I miss that? It's a failure every single time that a patient comes in. You have that patient's full attention, and we must use that opportunity to the best possible positive outcome.